Hi, everybody.
Hello.
I'm Dr. Carolyn Alexander, and I warmly welcome our partner, Dr. Diana Chavkin. We're so excited today to talk about how to improve fertility for future motherhood. And I'd love to have Dr. Chavkin start first and introduce yourself.
Great. Hi, thank you so much for the warm welcome. I'm so incredibly excited to be here at SCRC and to be doing this webinar with you
Are you
today here.
on mute or
Do you not hear
is,
me? Sorry, do you hear me?
Yes, we can hear you, Dr. Chavkin.
Okay. Sorry about that. Anyway, so I'm so incredibly excited to be here at SCRC and so excited to be here with you, Dr. Alexander, doing this webinar. It's just been such a pleasure. I joined SCRC about a week ago. I've been in practice for about 15 years now, in LA about 10 years. And I'm just so excited to be part of the SCRC team. And just to introduce myself, so I'm an RE. I specialize in third-party reproduction, reciprocal IVF protocol optimization, and infertility related to DOR and unexplained infertility. I'm from New York originally. I went to Columbia for my undergrad. I went to NYU for medical school, and I did my training at the University of Pennsylvania. Like I said, moved out here about 10 years ago, and I'm just so excited to be here, to be practicing in LA.
Wonderful. We're so happy to have you. I feel like we're spirit animals. We get each other, like we have a similar sort of sense of humor too.
Yeah,
I'm
absolutely.
I'm Carolyn Alexander. I'm one of the fertility doctors here too. And I was in academic medicine at Cedars for many years and have been proud to be a part of SCRC for many years. All my research originally was on polycystic ovary syndrome and understanding recurrent pregnancy loss as well as adrenal hyperplasia. And then now here I've been more focused on optimizing egg freezing as well as IVF patients and third-party reproduction as well. And I do see a lot of oncofertility, so patients facing cancer who want to freeze eggs or embryos or free sperm. And I hope if you have questions, please feel free to put them in the chat. We're happy to answer them and we're happy to think things through together. I think that's the beauty of what we do is every case is very specific and we really try to help every individual to the best of our abilities. So, and that's really been the joy of the job. So next slide. So at SCRC, our lab started in 1999. Our embryologists, we love them so much. They work really hard every day here with us. We work closely with them. It's an on-site embryology team. We have a sister embryology lab in Santa Barbara. It's an identical setup. It's beautiful there too. And we have an office in Ventura and Pasadena where patients can get monitoring and it's easier for them if they live near there. And then they come to Beverly Hills or Santa Barbara for the egg retrieval or embryo transfer. We keep the eggs and embryos here on site. A lot of people ask us that question. And we have embryos that have been thawed many, many years later and eggs that are 14-year frozen healthy babies, which is a testament to the team in the lab. They're very dedicated. Next slide. In terms of our lab, we have a certified director, double witnessing verification, so two people verify everything. We were one of the first places to do vitrification for the blastocyst, which is the embryo, and biopsy for PGTA or PGTM, and we can go into that in a little bit. We have an embryoscope, which is morphokinetics, that looks at analysis of 1,000 data points of the embryo as they develop. And sometimes when we're blessed to have many good embryos, the embryoscope data can kind of differentiate each of the embryos so we could optimize which one has a better chance to implant. It doesn't change the genetics, obviously, because that's the destined complement of chromosomes. But what it does is help us kind of figure out together with the embryologist which embryo could or may be a little optimal, better to implant. Next slide. Today, we're going to focus on what can affect your fertility, patient evaluation, the holistic approach, treatment options. You'll meet our team, and then questions. Feel free to put them in the chat, or when you have an appointment with your doctor, everyone can answer any questions available. We work as a team here too. Next slide. Dr. Chavkin.
Great, thank you. Yeah, and you just, speaking about the lab and all of the experience here at SCRC, I have to say that one of the main things that brought me here was SCRC's amazing reputation and the success rates of the lab, it's very well renowned, and so I'm very happy to be here because of all of that. And so today we're going to talk about what can affect your fertility. So some things here listed on this slide. So age, we'll talk about different medical conditions. We'll talk about some gynecologic issues and lifestyle. So age is a big one. We know that women are born with all the eggs that they'll ever have. And as women get older, they not only lose eggs in number, but eggs decline in quality, meaning that the chance that an egg will have a chromosomal abnormality in it will increase over time. And so the combination of that makes it such that a woman can have a harder time getting pregnant as she ages, but she'll also have a harder time having a successful pregnancy, meaning she'll have a higher chance of having a pregnancy that's potentially chromosomally abnormal, and therefore a higher chance of miscarriage. And so age is, unfortunately, just a fact of life, and that a woman's fertility will decline over time. Now, this isn't, anything to panic about, and it's not an on-off switch that, at a specific age, all of a sudden, there's, a specific downward spiral in terms of fertility. It is for most women a progression over time. And it's something we're aware about it, and it's something that I know a lot of us here at SCRC, we're big proponents of thinking about fertility preservation, either in the form of egg freezing or embryo freezing, so that as a woman gets older, she has the option of having a child at a later age than she would have otherwise, because she potentially froze her eggs at a younger age, or froze embryos at a younger age than the time at which she was going to use them. Polycystic ovary syndrome. So that is the most common reason why women have anovulatory cycles. So the normal course of things is that a woman will release an egg about every 28 to 30 days, and she will ovulate. And we know that a woman is ovulating when she gets a period once a month. If a woman doesn't get a period once a month, if she, skips multiple months, or sometimes there's heavy bleeding and then not bleeding for a while, we call that anovulatory bleeding, meaning she's bleeding and not truly ovulating. The most common explanation for anovulatory bleeding is polycystic ovary syndrome. Polycystic ovary syndrome includes multiple factors to make this diagnosis. And number one, we have to make sure there are no other conditions that are causing this problem, but also polycystic ovary syndrome is usually associated with a high number of follicles in the ovary. So there are follicles. The follicles are the pockets of fluid that have the microscopic eggs. And so polycystic ovary syndrome it consists of a situation where a woman will have lots of eggs, lots of follicles, but they're not being released regularly. They're not being released once a month. And so that is associated with the irregular bleeding. And of course, if a woman isn't releasing an egg and ovulating, well, then she's not going to be able to get pregnant. And PCOS, like I said, is the most common reason why anovulation occurs. Polycystic ovary syndrome is also associated with sometimes elevated weight, elevated BMI, and so that's something we need to look out for as well. because there are modifiable things we can do to potentially push someone into a situation where maybe if her weight was elevated and she was having symptoms of PCOS, if she can lose some of that weight, well, then we can get her into a situation where she might ovulate regularly, even if she does have PCOS. Endometriosis is a condition in which the cells that usually just line the uterus, so the endometrial cells, implant outside of the uterus, so in the pelvis, so either the fallopian tubes or outside of the uterus. And that can cause, number one, pain with menses, but also pain throughout the cycle. But it can also cause scar tissue. It can cause cysts on the ovaries, and the structural changes that occur make it such that it can be harder to conceive if there is scar tissue potentially in the fallopian tube or around the fallopian tube. And also the effect of the endometriosis on the ovary itself can cause a lower ovarian reserve situation. Certain medical conditions like metabolic syndrome, diabetes, thyroid disorders, those all can also impact a woman's ability to conceive. And so all of those things need to be tightly controlled and regulated, just to make sure not only that she can conceive, but also that when she gets pregnant, she'll have a healthy pregnancy. Unfortunately, a lot of medical conditions that, may be somewhat okay before pregnancy, sometimes in pregnancy, because of the stress of pregnancy, can really tip the situation such that medical conditions can get worse in pregnancy. So we need to make sure that they're all tightened up and optimized, and the health situation is optimized prior to pregnancy to get pregnant and also to have a healthy pregnancy. Cancer treatments. So, it's been amazing. Our field of oncology in general, it's so amazing to live in a time now where, people can get a cancer diagnosis and still live a very long, beautiful, healthy life because of the treatments that are available now to people. So the advances in chemotherapy care, radiation care, in adjuvant and neoadjuvant care has been absolutely amazing and life-saving. However, some of these treatments are gonatotoxic. So gonatotoxic meaning that it can affect one's eggs. As I mentioned, a woman is born with all the eggs that she'll ever have, and things like exposures to chemotherapy, radiation can affect that egg count. And so, although chemotherapy may be necessary to save a woman or a man's life, it can affect sperm count and can affect egg count. And so it's important to keep that in mind. And again, that goes back to this idea of fertility preservation. If somebody knows that they're going to be exposed to chemoradiation, maybe we can, squeeze in a cycle of egg freezing or embryo freezing before that exposure occurs. Or after treatment, we know that potentially there might be lower ovarian reserve. And so someone that may have been able to conceive naturally, potentially before chemotherapy, afterwards, they may be in a situation where they have lower ovarian reserve because of those treatments. And so doing things like IVF or other fertility treatments can help. Blocked or damaged fallopian tubes, either due to scarring of endometriosis or due to scarring from pelvic inflammatory disease or other surgeries that may have caused scarring in the pelvis, can create a situation where the fallopian tubes are damaged. And the fallopian tube is where the egg and the sperm meet naturally. And if the fallopian tube is damaged, well, the egg and the sperm are not going to meet. And that's important to know ahead of time. Lifestyle, I can't emphasize enough, lifestyle is incredibly important. And it's lifestyle, not just a month or two, it's a lifelong lifestyle. So things like exposure to toxins like cigarette smoke is a huge one. Excessive alcohol or environmental exposures, all of those things can really affect our egg supply, our health, and our ability to conceive. And so we just have to really be careful with our exposures and our health, and just try to optimize that as much as possible, so that we have the ability to conceive for as long as we can. Next slide. So the definition of infertility. So the traditional definition of infertility is that if a couple or a woman has been trying to conceive for a year, we say she has a diagnosis of infertility. Now that is generally thought of for women who are less than 35. If a woman is over the age of 35 and she's been trying for 6 months, we don't say, okay, go ahead and try for another 6 months, because we don't want age to affect her so much so that when we go ahead and do treatment, the chances of a good outcome are going to be less. So we kind of have different criteria for less than age 35 and then over the age of 35. And it has implications for when we are going to intervene. So if we give a woman a diagnosis of infertility, that means it's time to intervene, because the chances of her being able to conceive on her own are going to be not that high. And so we want to intervene. And this chart here just shows you, so on the our horizontal axis, on the x-axis, you see months. So over time, you can see over up to 36 months. And on your y-axis, you can see % chance of conception. And so what essentially you see is that in the normal fertile, general population, the chance of conceiving in the first 3 months of trying, so assuming that there's that there is ovulation, and meaning an egg is being dropped and it's being released, the chance of conception is about 18% in a normal, fertile, healthy situation. As time goes on and a woman still hasn't conceived, we'll say, okay, well, it's no longer 18%. It goes down because she potentially should have conceived. So meaning as time goes on, if she hasn't conceived, we're starting to think that maybe something is wrong and she may not be able to conceive on her own. And then once we get to that certain point of 12 months, you really see that precipitous decline. You can kind of see that slope really spiraling down. And it doesn't mean that she's not going to be able to conceive at all, but the chances of her being able to conceive really does go down at the longer we wait. And sorry, and the one other thing I will say about that is that we want to intervene because the chances of our fertility treatments aren't going to work forever either. And so that's why once we get to a certain point, and especially when a woman was over the age of 35, we don't want to wait necessarily 12 months or 2 years, because then the chance of the IVF or other treatments working is really going to decline over time as well. Okay, next slide. And this, the heart of all that, the basis of all that is essentially this. So there's natural ovarian aging. So again, when we're born with all the eggs that we'll ever have. And this cross-section over here is a cross-section of the ovaries. And these kind of little circles are the germ cells. They're essentially representing what are going to be eggs that theoretically can be released one day. And what happens is that the eggs are kind of sitting in meiotic arrest, meaning that the chromosomes are sitting essentially all lined up, kind of sitting there waiting to ovulate, for that process to continue, for the meiosis to continue. And then when fertilization with sperm occurs, the meiosis continues even further, and then the chromosomes hopefully divide normally. The problem is that as the eggs are sitting there over time and as we age, the chance of those chromosomes splitting normally in meiosis 1 and meiosis 2 really declines, because we think that there's sort of like a stickiness of the chromosomes, and meaning that the chromosomes are more likely to be abnormal. But here what we're seeing is that the number of cells, which is up here in your vertical axis, the number of cells will decline over time. So even when a little baby girl is born, she has about 6 to 7 million eggs. By the time she hits puberty, that number goes way below 1 million. So even before she's ever even ovulated, the egg count declines hugely, right? And then over time, from the time of puberty until she hits menopause, she'll lose eggs over time because of ovulation, but also in the natural process of what's called atresia, in that eggs will be programmed to disintegrate and essentially die off on their own over time. And the idea is that as women hit menopause, by the time they hit menopause, there are essentially no eggs left, either because they've ovulated or because they've undergone atresia. And then you can really starkly, you can see that in these two cross sections. So on the one side, you see the cross section of the ovary at birth with all these millions and millions and millions of cells, of follicles, and then at the age of 50, right, you see, you know, 1 or 2, or essentially 0. Okay, next slide. So age factor. So it's, you know, to beat a dead horse, and I don't want to stress anybody out. It really is, though, at the heart of kind of what we think about and what we do. In that here on one side, so you see age and female fertility. So on your y-axis, on the vertical, you see per month conception, per month change of conception, and then age in years. And so you can see as a woman ages, her chance of conception will decline. The other graph here is the percent genetically normal eggs by age group. And this speaks to why, again, there's a higher chance of miscarriage and also a lower chance of fertility, lower chance of successful pregnancy, in that the chance of the eggs being chromosomally normal will decline over time. Now, one of the good news here, good piece of information is that, you know, if we freeze eggs at a young age, the chance of the chromosomes being normal depends on the age at which we froze the egg, not the age at which the woman uses those eggs. And so a woman can essentially lock in her chance of having a genetically normal egg at the age at which she froze those eggs. And as the eggs are frozen, they don't degenerate or disintegrate over time, and they don't undergo chromosomal changes as they're frozen, which is good news. Okay, I think that's it. Yeah, next slide. Thank you. So what is polycystic ovary syndrome? I kind of touched on it a little bit before. So it's the most common hormonal disorder in reproductive aged women. It's very common. Approximately 1 in 10 women have PCOS. As I had mentioned, it's the most common cause of irregular menses and ovulatory infertility. It's defined by ovulation dysfunction and androgen excess, and that can be either clinical androgen excess, so potentially male pattern hair growth, you know, either on the face or in the arms. It can also be elevated androgens as seen in blood work. And just to, you know, be very clear, this is not at the level of what you'd see in a man, but it is higher than what we would see for the average woman. And it has to do with the hormonal dysregulation. And it's often associated with impaired insulin response. And that's why women with PCOS are sometimes more prone to develop diabetes, insulin resistance, and metabolic syndrome. And, you know, the unfortunate thing about this is that women with PCOS are also more, you know, they're more sensitive to be affected by that. And the effect of it is more likely to be more severe. So, you know, they have to, and it's also sometimes harder for women with PCOS to actually lose the weight to put them in that better prognosis category. So they have to, you know, sometimes I think seeing a nutritionist and being just hyper vigilant can really put them in a much better place. And like I said before, can even swing somebody who has been anovulatory into an ovulatory state just by losing the weight. Although it's honestly probably one of the hardest things to do, but worth the effort. Next slide. Endometriosis. So endometriosis, again, is where the cells that line the uterus, so the endometrial cells, get developed in other places. So a normal uterus has the endometrial cells, the uterine cells just lining the uterine cavity. When those cells implant other places, either, you know, outside of the uterus, in the pelvis, on the ovary, and the fallopian tubes, it can cause scar tissue and issues, structural issues. Next slide. Medical conditions that can affect fertility: diabetes, hypertension, high blood pressure, extremes in BMI, fibroids. So fibroids, if they're, you know, in the uterine cavity or if they're in the muscle of the uterus, can impair implantation, and hormonal imbalances. And as I had said before, it's not just about getting these medical conditions under control so a woman can conceive, but it's also so that she can have a healthy pregnancy and a healthy baby and a healthy delivery. Next slide. So fertility preservation options for cancer patients. So again, as I had mentioned before, the field of oncology has really progressed in amazing ways, but it's really important for oncologists and for us to be advocates for the patients to say, okay, it's important obviously for people to get the care they need so they can survive their diagnoses and go on to live, long lives. But quality of life is important, and also an individual's hopes and dreams about their fertility and their family planning is also important. And so it's really crucial that we get the word out there and that it's offered to people before it's too late, before they're exposed to let's say chemoradiation. And so either sperm freezing, we do that in our clinic. That's usually one of the easier things to do out of all of these options. We'll sometimes have men come in before they're going to get their chemoradiation. We usually have them come in a few times to produce as many samples as theoretically they can, and that sperm can stay frozen. It stays frozen with us, and whenever they want to use that sperm in the future, we can thaw the sperm, we can thaw portions of the sperm, so that we can use them. Usually, because the amounts of sperm that we have, it's not an endless supply, it's a finite amount. So a lot of times we'll want to be really conservative with that sperm, and doing IVF is usually the most conservative approach rather than using it for an insemination. But that would, potentially be a conversation. Egg freezing. So again, if we can freeze eggs at a given point in time, that will give will give any woman a better chance of conceiving than she would if she were to wait until later. But especially if a woman's going to be exposed to specific toxins that we know are going to decrease the egg count, well, then she's going to have a much higher chance of being able to conceive in the future if we were to freeze eggs now, as opposed to waiting till later. Embryo freezing is also a wonderful option. Embryo freezing is it can be offered to single women if they want to use a sperm donor. So, even a woman who is single and doesn't have a partner, it doesn't mean that she can't freeze embryos. But of course, that limits the ability of her to use that with another partner, obviously, down the road. And so, some women who will do a cycle where they'll freeze half eggs and then the other half they'll make embryos, potentially with a sperm donor. But either option is good. Now, the one benefit I'll say about embryo freezing over egg freezing is that, well, with embryo freezing, we can actually test the embryo to see if it's chromosomally normal or not. With egg freezing, we can't actually test the egg to see if it's chromosomally normal. So it's a little bit more of an unknown as to what we have when we freeze eggs. But of course, it's a very, it's an in-depth conversation, and it's a partnership in terms of coming up with the right decision for that given situation. And cryopreservation outcomes. So outcomes are extremely favorable. So thaw survival is about 97%. Fertilization and cleavage is about 70 to 80%. And we're talking about frozen eggs here. So essentially, if we have frozen eggs, and we make sure to, especially in our lab, we make sure that we're freezing good quality eggs. If we're freezing good quality eggs, they are extremely likely to survive the thaw. Fertilization rates are also very high, about 70 to 80%, and implantation rates are about 20 to 40%. But again, depending on whether the embryo is chromosomally normal or not. So if the embryo is chromosomally normal, we know that it is from a given frozen egg situation, well then, in my opinion, the chance of pregnancy and successful pregnancy is essentially equal to if you got that egg from a fresh egg. And we know that approximately 6,000 babies are born. We know that there's no increased risk of maternal fetal complication and no increased risk for aneuploidy or malformation. And essentially, we say there's about a 10% clinical pregnancy rate per thawed egg, but of course that varies by the age at which the woman froze her eggs. So outcomes are good. Sperm freezing. So couples or an individual man may want to freeze sperm due to upcoming, let's say, cancer therapy, military service that may deploy him or her for prolonged periods of time, potential occupational risks that they know may be that they may be exposed to, or other personal reasons. So we would do routine screening for infection just to make sure that we got appropriate STD screening at the time that the sperm was frozen, so that we know that it was safe to use. We can use a semen sample by having the man ejaculate, or we can do surgical sperm extraction if he's unable to ejaculate. Our lab here will evaluate the sperm for quantity and quality. The sperm will then be frozen, and then the sperm can be stored indefinitely. There's no expiration date, and we don't find that sperm that's been stored for a longer amount of time has any less viability or any less success than sperm that's frozen for less time. Okay, next slide. So patient evaluation, extremely important. Medical history is probably the most important part of this whole evaluation, trying to understand what they've been through so far, how they've been trying, what their workup is. I think also very important is trying to understand what their hopes and dreams are, what they may be doing in the next year or 2 or 3 years that may limit their ability to have the family size that they want. And what is the family size that they want? What are their goals? Because sometimes, a woman or a couple may come to me and say, okay, we're trying to conceive, we want to have a baby. I think one of the most important questions is, well, how many babies do you want, right? How many children do you want? Because we have to think about that. If a couple is having trouble conceiving their first child, but they know they want 2 or 3, our goal has to potentially do something to increase the chance that they could have the family size they want. And that might mean freezing some chromosomally normal embryos so that we're not just focused on the first child, but having enough embryos that are normal frozen for later, because things don't get easier over time. Physical examination is extremely important. A lot of things come up. So, people sometimes aren't necessarily so good about seeing their primary care doctor or their general OBGYN, but they know they want to have a baby and they come to us. And sometimes when they come to us, we actually, diagnose diabetes. We diagnose thyroid disorders. We diagnose, we get a clue that there might be lupus or what have you, right? There might be medical conditions that have gone undiagnosed and they come to see us focused on fertility. We see them and we see, wait, there's a bunch of other things going on that need to be addressed, which potentially are affecting their fertility and definitely affecting their health. And so it's crucial that we think about that and we pick that up a lot of times in physical examinations. Diagnostic testing. So I usually kind of break it down. Well, you need an egg, you need a sperm, and you need a way for them to meet. It's kind of very simple. And the sperm part isn't that complicated. So usually we'll recommend a semen analysis as a basic way to look at the count and the quality, make sure that there is sperm there, right? Sometimes men can be ejaculating and they're ejaculating semen, but sometimes there's no sperm there. So it's very crucial. We just make sure that there is some sperm there and that there's enough. Assessing a woman's eggs is extremely important. And one of the most important ways to assess a woman's eggs is actually medical history. So if a woman tells me that she's not on birth control pills and she's getting a period essentially every 28 to 30 days, I can basically say with almost 99% certainty that she is ovulating. So that's really important. But some other diagnostic testing associated with egg supply has to do with AMH levels, hormone levels. FSH is another hormone test that we use to assess ovarian reserve, and looking at follicles, so a follicle count, in which we'll do an ultrasound to look at the follicle. So the follicle count and the follicle number that we see at any given point, usually at the beginning of the menstrual cycle, gives us some indication of what her ovarian reserve, what her egg count is. and doing things to evaluate the fallopian tubes to make sure that there is a way for the egg and the sperm to meet. Hysterosalpingogram is an X-ray dye test where dye is injected into the cervix, into the uterus, pushed out through the fallopian tubes to make sure that the fallopian tubes are open. Anyway, we collect all this information and then we put it together and come up with a plan. Next slide. So this is some of the diagnostic testing that I had mentioned. So AMH, anti-Müllerian hormone level, and then FSH and estradiol. So AMH is one of the newest, best developments in the fertility world over the past 10 years or so. So AMH is a hormone. Essentially, we think of it as a hormone that's in the woman's body, at least, is secreted by the follicle, by the cells that surround each follicle in the woman's egg, so in the woman's ovary. So essentially, the more eggs a woman has, the more follicles she has, the more cells she has that are secreting this AMH. And so AMH has become this really great way to understand what a woman's ovarian reserve is or what her egg count is. And we know that as a woman ages, she'll have a lower ovarian reserve and a lower AMH. And we essentially, we don't say, oh, that AMH is normal, that AMH is abnormal. They're essentially age-based averages that are supposed to be essentially normal or on average for a given woman's age. So at the age of 50, it's actually normal for an AMH to essentially be 0 because at that age, essentially she has no eggs left, right? And so her AMH should be 0. And then it kind of goes up as you go down in age. So at the age of 40, essentially an AMH on average is around 1. At 30 on average, it's around 2 or 3, right? And as you get younger, you get higher in AMH. And so if I see a woman and her AMH is potentially less than I would expect based on her ovarian, if her AMH is lower than I'd expect based on her age, well, then that potentially can help to explain the infertility if she has lower egg count. The FSH and the estradiol, also that's a hormone, that the FSH is a hormone that's produced by the brain in response to the follicles that are developing. So there's this negative feedback loop in that the more follicles there are, the more estrogen there is, the lower the FSH. And so when the FSH is high, that's essentially an indicator that the brain essentially has to scream louder at the ovaries to get to work. And so a higher FSH is usually representing the fact that there is a lower egg supply. The issue with the FSH and the estradiol level is that that's very dependent on the time of the cycle, and it can't usually be done while a woman is on birth control pills. AMH is a little easier because it can be done at any point in time of the cycle, of the menstrual cycle. The ultrasound over here also, this is a picture of the follicles. So these black circles, I don't know if you can see them, but the black circles on the ultrasound, that represents a follicle. So again, a follicle is a pocket of fluid that has the microscopic egg in it. We can see these follicles on ultrasound, and we use the ultrasound to give us some sense of what the follicle count is, what the ovarian reserve is. Next slide. So the HSS, so the hysterosonogram or the sonohistogram or the SAS, so there's so many words for this. It's basically a water ultrasound. It's basically an ultrasound where we take saline or salt water, and we put it into the uterine cavity. It's usually an office test, meaning you're awake for it. It's not usually very uncomfortable. We do it here in the office. What we do is we fill the uterine cavity up with a little bit of fluid, kind of like a balloon, and that helps distend the walls of the uterine cavity. And so it makes it so that you can see something protruding into the uterine cavity if it's there. So if there's a polyp or a fibroid or something that shouldn't be there that may impair implantation, you won't see this nice black cavity like you would see on this one picture here on the left-hand side where it shows you the saline in the uterine cavity where it's just this black circle or black oval shaped. On the right-hand side, you see kind of something protruding in there, and that's either a polyp or a fibroid, but that can easily be removed and then definitely improve the chance of a woman conceiving because that gets out of the way, and then the embryo has room to implant. Next slide. hysteral salpingogram. So this is an X-ray dye test. So this is done in a special radiology center where there is X-ray. We have that ability to do that here, thankfully, at SCRC, which is really cool. But essentially, it's kind of similar to the water ultrasound, but the extra good thing about the hysteral salpingogram is that it actually assesses fallopian tube patency. So what happens here is that radio-opaque dye is injected into the cervix, into the uterus, and you can see the uterine outline, so you get to kind of see some structural abnormalities or understanding what's going on with the uterine cavity, but then also you're seeing the dye pushed out through the fallopian tubes. And so what happens when the fallopian tubes are open is that this dye spills out through the fallopian tubes, spills out into the peritoneal cavity, and we say, okay, great, the fallopian tubes are open. But if for some reason it's not spilling, or it's kind of like filling up the fallopian tube and dilating it, well, then we know that there's some sort of issue that needs to be addressed. If the dye is not coming through, then the sperm is unlikely to get through well either, and then either will the egg, and so a pregnancy can't occur. Next slide. Great, thank you. I'll hand this up to Dr. Alexander.
Great. I love hearing all that. It really was so thorough and clear, and I think it helps every time I hear how the philosophy is, and you're very detail oriented, so it really helps us get through step by step what we're trying to understand for each patient. So next slide. So it's important to avoid toxins. I think the holistic approach, as Dr. Chavkin said. So in general, everything in moderation, because a lot of patients do have some red wine, some beer. We can't say to cold turkey everything. So 2 glasses a week is probably reasonable, but during the fertility treatments, because they rely on proper kidney and liver function, we don't want too much alcohol during that time. As well as some men who binge drink or have more hard alcohol, we do see the sperm quality not be as ideal. So both partners have to work together to make it the best outcome. THC or marijuana and vaping can impact egg and sperm quality. I think of it as kind of suppressing the pituitary, which is the master control gland. So in some men, they'll over time, if they have a lot of marijuana, they'll get a teeny bit of hypothalamic issues. And so it's important for them to not cold turkey what they're doing, to go to half the amounts and then again half the amounts a week or 2 later, and then we transition them down off of it. If they're using it for sleep, we can add melatonin and sometimes other sleep agents to help. We can work in conjunction with the primary care doctor. Tobacco is very important. I just had a patient where I convinced her to think about Chantix, which is a medication that helps us really cut that craving for nicotine. And she was really happy with that suggestion because her primary care doctor maybe didn't mention it over time. And so that's helping us, because during the fertility treatment, especially in women who've had or are having tobacco within the month or 2, there's a higher risk of kind of a thickening of the blood system, so a higher risk of blood clotting, such as deep vein thrombosis or pulmonary embolism, when we're always afraid of that. And so it's a higher risk in patients who have a family history, tobacco use, sedentary lifestyle, long flights or long car drives, especially when they're on the fertility treatments, which our goals are to get good eggs and many eggs, which can produce estrogen, and estrogen's a risk factor for those things too. So it's not just tobacco, because tobacco's bad and has a risk for cancer and everything like that. It has bigger ramifications for what we're trying to protect you from too during the fertility options and treatments. So next slide. In terms of nutrition, it's also sometimes Friday night to have like some sweets or pizza or something. That's okay, because people always say, did that hurt anything that I did that? No, it's everything in moderation. But over your 7 days of nutrition, you really want to amp up fruits, vegetables, lean meats. Sometimes the acai berry has some evidence that it might have antioxidants that are helpful. Some patients who are vegan, we have a discussion with them about certain vitamins they may be like lacking just from the vegan diet. So we could talk about it, but we tend to tune in. One of the chat questions was, are there specific fertility nutritionists? I think there are, but what's important is just over the few months before fertility treatment, and when I was going to start to try for my second child, I was really focused to try to get back to my pre-pregnancy weight and really amp up my cardio, because I think I was really focused on work and breastfeeding and everything like that. So I think it's important to recognize that nutrition, exercise, getting back to your ideal body weight, if that's an issue. If it's too thin, when the body mass index is less than 18, it's also a little harder to ovulate. The system says, why should I ovulate? There isn't adequate nutrition. So it's important to recognize that too if we're doing calorie restriction. Sometimes with some men, if they go on the 16-hour fast and are doing intermittent fasting, we'll see the sperm quality change a bit, and you would think it would super duper improve, but sometimes it's the opposite. And so every person's very unique and it can have implications. But with men, we encourage them to eat walnuts. There's a UCLA well done study on omega-3 and 6 and walnuts. And then we really encourage them also to avoid artificial sweeteners, too much hard alcohol, and avoiding the heat to the testicles too for impact on sperm DNA. Next slide. Prenatal vitamins is really important. Folic acid prevents spina bifida. Vitamin D levels of 30 to 50 have some evidence to prevent preterm labor, so that's really important. Metformin in patients with polycystic ovaries can cause B12 deficiency, so it's important to think about amping up the B12, especially in nutrition or as a vitamin, because that can have an impact with metformin. If someone's had the gastric sleeve or gastric bypass, micronutrients are hindered from being absorbed in the stomach. Some patients, if they have really heavy periods, can get ferritin to go down. And we found that the embryos implant at a higher success rate if ferritin's over 10. So sometimes we work with your primary care doctor to improve your ferritin to get it better. CoQ10 has an interesting mechanism. It improves mitochondrial function. Sometimes when we're older, you can have many mitochondria in the egg, but they don't function as well. And so CoQ10 may be a mechanism to improve mitochondria or the energy function in the egg, as well as in sperm quality too. And vitamin D has anti-inflammation. And a lot of patients with endometriosis or PCOS may have very low levels of vitamin D. And so it's important to think about that when you're preparing for pregnancy too. Next slide. So there's always hope. I always believe there's a golden egg for everyone. And so I think that helps us stay focused on the goal. And so trying to keep a positive mindset. We work closely with our teammates here. It's a collaborative effort. We talk to the embryologists a lot. So we always are in discussions, how to improve egg survival of the egg thaw, how to improve the embryo implantation rate. So there's a lot of discussion to help every couple or every individual. I think it's important to get a sense on the embryology lab and how long they've been there and all those details. But I think it's important to feel comfortable with your physician as well as the team and the embryology lab too. Next slide. So here we do egg freezing, embryo freezing, sperm freezing. We got a question also for the IUI, intrauterine insemination, which helps a lot in cases where the semen analysis is borderline and perhaps the patient's ovulating really well. She feels a positive ovulation predictor kit. The uterus doesn't have any fibroids or any impact to the uterine lining, the fallopian tubes are open, and the ovarian reserve is good. IUI can help in mild male factor cases, as well as in some patients where we want to talk about the options before in vitro fertilization or egg freezing or embryo freezing too. Surrogacy is important. Some patients are born with no uterus. It's an anatomical thing that happens. Some patients had an emergency C-section and then had bleeding, have no uterus. We do see some patients where a cardiologist calls us and says they're not allowed to carry because they have a cardiac issue that's not safe in pregnancy. So there are many, many reasons for surrogacy. Sometimes patients are on medications where it can be so harmful to the early pregnancy that it's not ideal. So they have to think of the pros and cons of using a surrogate. But we work hard to help patients get ideal surrogate, someone healthy, kind, who will listen to all the medications. We talk to them a lot. We make sure they're on prenatal vitamins, and we have a checklist to make sure the surrogate's as healthy as possible so that our patient gets the ultimate full-term healthy baby. So it's a very big effort to do and steps, but along the journey, we're together on it and working hard. Donor eggs are either frozen eggs or fresh eggs. Frozen eggs tend to arrive quicker, but with the frozen eggs, they come in little sets. And so sometimes we could get 6 to 10 eggs that give us many good blastocysts or embryos. And sometimes, depending also on sperm quality, we may or may not get a good set. And so it's important to think about the frozen eggs. We've had a lot of success with them, but we try to ask in the egg retrieval day for that egg donor, how did things go? How many eggs were obtained? How high was the estrogen? There's a lot of tips to help see what we can do to get a better success. A fresh donor egg takes a little more time. It takes 3 to 6 months to find an ideal patient. We look at genetics, which is really important. So the male could carry, let's say, sickle cell traits. We have to triple check that the egg donor doesn't carry sickle cell trait or hemoglobin C or thalassemia and things like that. We also make sure that the egg donor's healthy, on vitamins, her egg supply and egg quality levels are good. Usually most of them are age 21 to 29, so they're pretty young. And we tend to try to avoid hyperstimulation syndrome in them because that gives us better egg quality. And then with sperm donors, we work with anonymous sperm banks or directed sperm donors where it's someone you may know but are not sexually intimate, and that's called a directed sperm donor. We really want to make sure he's also having a healthy vitamin D level, avoiding marijuana, tobacco, hard alcohol, those types of things. So I usually, if it's a directed donor, I'll sit with them, have a heart-to-heart talk about strategy. Sperm takes about 72 days to build up. So if the man is on certain medications such as Rogaine for their hair or Propecia and things like that, we have to tell them to please transition off certain medications so that we can get a better sperm outcome for especially a donor sperm or a partner sperm. Next slide. So intrauterine insemination, we bring the patient in on day 2 or 3 or 4 of the menstrual cycle to count the follicle count, as Dr. Chavkin mentioned, and look at the uterine lining. This is after we've already prepared a lot of tests called the checklist, which is ideal thyroid level, prolactin, vitamin D, make sure the fallopian tubes are open, the semen analysis is healthy. And then we bring you back a few days later, around day 7 or 9, so that we don't miss when you're going to ovulate, because some patients may ovulate earlier or later. And so we decide which protocol is going to help super ovulate or help ovulation induction. And we monitor you. And then there's something called the HCG trigger shot that helps loosen the egg from the sidewall, and it helps mature the egg. So when it ovulates, 36 hours or so, we usually do 35 to 38 hours, we place the sperm in. Causes a moment of a cramp. You're here for quite some time because you have to lay there for a bit. And we place the sperm carefully to the top of the uterus. And then we have you start progesterone usually a few days later to help support the early pregnancy. And a pregnancy test is 2 weeks later. The success with IUI can vary depending on your age, your AMH, your FSH, the sperm quality. And typically after 3 tries of IUI, the success starts to plateau. So we would have a discussion of what to do. Some patients who are using donor sperm and have never tried to be pregnant, they ask us, do I have to do the fallopian tube evaluation? It's a bit uncomfortable and cost factor. We don't have to do it, but we have had cases over many, many years of doing this that you do 3 IUIs and then figure out the tubes aren't necessarily open or patent, and we wished we had done the test sooner. So it's important to weigh the pros and cons of any test we order. And it's a team effort, like Dr. Chavkin mentioned. It's really a group discussion and trying to optimize you. Next slide. So for the egg retrieval, it tends to take us a month to prepare you. So prenatal vitamins, vitamin D, make sure your vitamin D levels optimized, make sure your thyroid's not off, make sure you're up to date with your pap smear. If you're over 40, it's important to think about a mammogram or breast ultrasound. If you're under 40 but have a strong family history, we still try to think about it together, what to do. A breast ultrasound's no radiation, so it's good to think it through before you're going to take fertility medications. They've been around since 1970. The medications are called follicle stimulating hormone and luteinizing hormone, and they work together to tell the follicles, instead of ovulating the one lucky egg for the month that you were going to potentially ovulate, we tell all the follicles, okay, guys, we're trying to get a group of follicles together in synchrony to ovulate. You can feel breast tenderness, headache, mood swings, thirsty, constipation sometimes. So think about magnesium or a stool softener like Colace. There's about 5 or 6 important visits. We open at 6:30 in the morning. And so some patients want to get in, get out. We can watch the images. And so then we talk to you on the phone. Hey, we looked at all the images. This is what you should do. Or it's growing really well, or the follicles are hindered and we need to think about what to do. So there's a lot of discussion. During the 10 to 12 days of FSH and LH and hormones, we really want you to eat a lot of protein, take walks, no vigorous exercise because the ovaries can turn on the blood supply. That's called torsion. And it doesn't happen frequently, but it's always on our radar. So it's important to not have jarring activity. We don't like any unprotected intercourse during the shots too, because we don't want sperm anywhere near 5 to 20 potential eggs. So we don't allow that. And then there's an important trigger shot. It's the most important shot of the whole thing. It can cause hypoglycemia, so make sure to have some orange juice or trail mix ready. That night is timed to when the egg retrieval is. On the egg retrieval day, no food, no water, no vitamins in the morning. If you're on blood pressure medication, we encourage you to talk to the anesthesiologist to discuss, do you take the labetalol, nifedipine or not? And we can talk about it. That morning, we'll give you an IV and then a little bit of medicine to relax you so that when you start to fall asleep with the propofol, which is IV, we can carefully with a thin needle get each follicle to drain, and the egg has loosened up from the sidewall from the trigger shot, and we carefully get the egg out. The day before the egg retrieval, we check LH, HCG, progesterone, depending on which type of trigger shot you took. And we want the LH over a certain value, progesterone over a certain value, HCG over a certain value, because we have targets that prove that you absorbed the trigger shot well so that the eggs can really pop up and develop. So when the egg retrieval is happening, we know in our hearts that your trigger shot was absorbed properly. We have had patients over the years say, I spilled some, I didn't take it all, I didn't take it at the right time, but it's one of the most important shots of the whole 10 to 12 day process. And some patients take longer days, but that's the average of the days. The 7 days after the egg retrieval the most common phone call is constipation. Some people feel headache, mood swings, you might feel out of sorts a little bit. And so just think 7 days and it tends to feel better, but really not to do vigorous exercise or intercourse for 10 to 14 days, depending on what your doctor recommends. It's important to also, during the process, if you feel any symptoms, let your team know. Because I think a lot of our patients say, I always felt like really open to tell you everything. I felt like I was this or that, whatever symptomatology, we rather know. So if you have asthma and it's getting exacerbated, tell us right away. If you have rheumatoid arthritis and you're feeling something, we rather know because we can titrate the medications and jump in and help in any way possible too. The period that happens 10 to 12 days after the retrieval is pretty heavy and crampy. It's a little more exacerbated than your usual period. And if you've been on the birth control pill, you could go back on the pill, but you have to ask your doctor too. And then the process after the eggs are retrieved, the doctor will keep you posted on every step of the journey from there. Next slide. Oh, so this is a really nice picture. This is the vaginal ultrasound with the thin needle, and the needle carefully goes into each circle, which is the follicle there. And a lot of people ask us what's in the fluid of it's mostly protein, albumin. So that's why I encourage eating lots of protein and antioxidant rich foods. And then the egg is smaller than a grain of salt. And so they carefully clean off the egg. They'll either freeze that egg or fertilize the egg. Next slide. Oh, the embryo development's so beautiful. So the egg is one cell. It's the largest cell in the human body. We gently place the sperm in with either intracytoplasmic sperm injection or inseminate the egg with 20,000 sperm in the dish. And the next morning, we're hoping to see 2 pronuclei, which is the first moment of fertilization. Then over 7 days, we watch the embryo till the 7th day midday, and we can watch the embryo develop to what's called the blastocyst, which has the inner cell mass and the trophectoderm, the outer rim. And they get a grade for the inner cell mass and the outer rim. And here's an image of ICSI. I don't know if you guys can see this, but it's pretty fascinating. So the egg is held by the pipette and perpendicular to the polar body. They immobilize the sperm and place the sperm into the egg. And then the next morning we know if it fertilized. Next slide. Oh, this is morphokinetics. So this is an embryo. And initially, when this first came out, they could almost predict which embryo may or may not have a chromosome problem. We do take a few cells off the outer rim of the blastocyst. It's called a trophectoderm biopsy, PGTA, or aneuploidy screening. If you carry a gene such as the early Alzheimer's gene or both partners carry sickle cell gene and we have to verify that the embryo didn't get a double copy, we would take the few cells. The DNA gets amplified and then they check for 2 copies of each chromosome. Then they'll do a deeper dive with a genetic probe for the specific gene that may run in your family. We just had a patient too. I mean, we see any type of gene, but if it's a specific gene that you want us to target, it would only be testable if you or your partner had the gene. Because sometimes people say, yeah, this runs in my family, I want to check for it. We want to help and try, but that's not possible if it's polygenetic, where it's not a specific gene. Next slide. Oh, so here we're doing a promotion. I was really proud. On April 22nd, we did free AMH for a lot of patients came in to the first floor in our office, and we high-fived them. They were just empowering themselves to know what's my AMH. It's not a perfect test. It's used in conjunction with all the other ovarian reserve tests, how your periods are, and everything Dr. Chavkin kind of touched on. But I think it was nice because interestingly, a lot of the patients had really good AMHs. So that was a blessing. And then if an AMH is borderline or low, it's good to evaluate why and talk to your OBGYN and try to understand. Next slide. Welcome, Dr. Chavkin. We're so happy to have you with us. And it's such a joy to even, like I said, I can't wait for a coffee tomorrow too. So
Thank you.
I think we
It
have
was
some
a great-
questions. Our whole team is wonderful. Dr. Suri, Dr. Danzer, myself, Dr. Maxwell's in Santa Barbara, and Dr. Chavkin's here in our Beverly Hills office. And so everyone works closely together, but we take care of each of our patients, but we work closely. If there's a challenging case, we talk about it. We have an ethics committee we talk to the embryologists a lot. It's a very much a collegial group effort to help people. And then the questions, one of the questions was, how do you evaluate the fallopian tube? But it came up, maybe you would like to touch on that one if you, I don't know if you saw that question.
Yeah, so I think it was one of the, how can I find out if my tubes are damaged from my endometriosis? So yeah, hysteral salpingogram would be the best test. So that's the X-ray dye test where, I mean, you probably come to see us first for an initial consultation. We'd have a whole conversation. And then one of the things we would send you for would be a hysteral salpingogram. Again, where they inject dye into the cervix, into the uterus. They watch the dye come out through the fallopian tubes, and then we'd get the images in the report, and we would discuss that with you. And not anything I would stress about. I wouldn't say that just because you have endometriosis, that means that your tubes are necessarily affected. Most women with endometriosis don't necessarily have tubal damage, but endometriosis is a risk for tubal damage. Something to think about.
Yeah, let's see.
And I think one of the questions also on here was, do you help with IUI? And you'd written, yes, definitely. So IUI is absolutely one of the first line treatments that we offer, as Dr. Alexander said, for mild male factor, as well as for unexplained infertility. It can be first line.
One of the questions was about ovarian tissue preservation in prepubertal girls. They can do that at UC San Diego has a protocol, and I think they've had the cortex survive the thaw and make an egg, but we don't do that here.
Yeah, and I think, and the question also is that she is 38 years old, is a healthy AMH, right, and interested in fertility preservation. I think we would say, a better option in that situation for fertility preservation as opposed to tissue preservation would be egg freezing and embryo freezing. I mean, at the moment, tissue preservation, although in theory, it's great. And I think one of the hopeful things about it is that maybe one day in the future, if we have tissue, then we can potentially get thousands and thousands of eggs one day from that tissue if we have that frozen. Or if you have the tissue frozen and then you transplant it back in your body later on when maybe you have fertility issues, okay, maybe you're in a better situation. But I think those ideas are a little bit unproven yet and somewhat experimental. But the egg freezing and the embryo freezing is the more tried and true fertility preservation, more standard of care options.
I saw one of the questions was in terms of the AMH chart. We can put it back up, team Layla. Can we put the AMH chart back up? Someone wanted to see it in more detail.
Yes. Sorry if I went through that too quickly.
Oh, no, I think it's always interesting to see him at that
Yeah,
level.
no, the numbers are good to review. I mean, I think just the main take-home point for that chart, though, is that, as we age, our egg number will decline and our AMH will decline, and they're essentially age-based averages. And so if, a woman comes in and her AMH is potentially lower than I'd expect for her age, well, then maybe we have to think about more aggressive, more a faster time course to treatment or potentially to fertility preservation. And I will say that, it goes for the reverse true. If somebody comes in and their AMH is potentially higher than you'd expect for your age, it doesn't necessarily mean, oh, okay, this person is not going to have fertility issues or potentially they shouldn't think about treatment. I actually think about AMH as a way to help me gauge what starting dose of medication to put somebody on to get the best outcome possible. But I really use history and kind of desires for family as to what treatment options to do. So if somebody's been trying for a while and they want to have 3 to 4 children, but their AMH is maybe a little bit higher than I'd expect for their age, I don't necessarily say, okay, well, let's do nothing, because AMH is a number, but it doesn't tell us everything, and it can help us guide every step. So I think it's just important to kind of put that number into context. And the other thing
Yeah.
is also AMH, again, it doesn't tell us much about quality, right? The quality meaning whether the egg is chromosomally normal and whether that embryo is going to be chromosomally normal. That's determined based on age. And AMH, although a woman potentially, in her late 40s might have a high AMH. That's great because that tells us something about egg number, but we're, concerned still about egg quality and the chance of eggs being chromosomally normal and therefore embryos being chromosomally normal and hence a successful pregnancy is not going to be very high as we age, even if the AMH is okay.
Yeah, one of the questions was if they did the diagnostic tools before the visit. We have to still dive in deep on how was puberty, menstrual cycle, your health issues, all the details of lifestyle modifications and stuff like that, and make sure, is there anything we're not thinking of, like autoimmune issues, or if you have a family history of blood clotting disorders, other things that can pop up in the conversation. And then we make a treatment plan together, depending on your pre-testing that you've done. So you asked, what does the first visit look like if I've done all the tests? There's still a bit to discuss and go over too, for both partners as well. Yeah.
Absolutely.
Thank you guys for such wonderful questions and for watching this, and we're happy to help in any way possible. And Diana, any other questions or comments?
I don't know. This was so fun. I love doing this with you and I love the questions. Thank you everybody for your participation. So happy we can do this by webinar. But I remember back in the day we used to do this in person and it was a little harder and traffic and everything. So it's so nice that we can do this online and yeah, it's great. Thank you for tuning in.
Okay, take care. Cheers. Bye.
Bye,
Be well,
everybody.
everybody. Safe journey.